The objectives of the talk is to first define a master athlete, outline the electrophysiological, anatomical, and functional cardiac changes seen in master athletes, describe the prevalence of coronary atherosclerosis in these athletes, and appreciate differences in plaque morphology between athletes and sedentary individuals. So before I start, I do want to highlight the important benefits of exercise, which I'm sure most of us in this room will be very familiar with. Individuals who exercise regularly and moderately enjoy a 50% risk reduction in coronary events. They have favorable blood pressure and lipid profiles, and on average live 3 to 6 years longer. And there's a growing group of athletes, master athletes, who want to reap the rewards of these benefits. Master athletes are defined as individuals who are over the age of 35, who exercise regularly. And some of them are competitive, as you can see here on the right, but the vast majority are recreational. And they make up the majority of mass participants in endurance events. In this year's London Marathon, over a third of participants were aged over 35. Now, if we look back 20 years ago or so, that number was almost half. So this is a growing group of athletes whom we should really acknowledge. Now, you've heard some excellent talks today about the young athlete's heart, but we know very little about the effects of lifelong endurance exercise on the heart, which, of course, is subject to numerous factors, including toxins and infections, lifelong cardiovascular risk factors, the normal aging process itself, genetic predisposition, and the stress of exercise. Now, there has been some studies looking at individuals who've taken part in lifelong endurance exercise, but these studies have been limited by small sample sizes, the inclusion of individuals with confounding cardiovascular risk factors, and neglecting the female athlete. So we set up a veteran athlete study at St. George's, where we recruited 152 male and female athletes who were aged over 40, had taken part in more than 10 years of competitive endurance exercise, and most importantly, were free of cardiovascular risk factors. These were compared to healthy controls who were age, gender, and ethnicity matched. And both groups underwent a gamut of investigations. But for the purpose of the talk, I'm just going to concentrate on three. Data from the ECG, the Holter monitor, the cardiac MRI, and the CT coronary angiogram. So these athletes were recruited by way of adverts placed in popular athletics magazines. They had an ECG, a 24-hour heart monitor. We assessed dimensions and fibrosis by way of a 1.5T cardiac MRI. And all individuals had a CT scan, inclusive of calcium scores and CT coronary angiograms. Now, just before I start and talk about the results that we found, I just want you to appreciate that the controls and the athletes were matched in terms of age, gender, and ethnicity. They had similar indices of blood pressure and cholesterol, and similar Framingham risk scores. But on average, the endurance athletes took part in over 30 years of competitive exercise, and on average performed around 8 hours of exercise per week. And as we would expect, they had a higher VO2 max. We'll first start with the arrhythmias observed in athletes and controls. And if we look at different types of arrhythmias, sort of subdivided here in narrow complex tachycardias, pauses, air, flutter, and non-sustained ventricular tachycardia, we can appreciate that the athletes had much higher prevalence of all forms of arrhythmias. Now, certainly the case for narrow complex tachycardias, pauses, AF, and flutter has been previously reported. But certainly what raised alarm was a prevalence of around 8% of non-sustained ventricular tachycardia in our veteran cohorts, all of which were males. And this is an example. So this is a 52-year-old male cyclist who on the Holter monitor had a 14-beat run of ventricular tachycardia. And mind you, was asymptomatic during this. So as I've mentioned, there have been certain causes put forward to explain AF flutter, but certainly the prevalence of ventricular tachycardia as to the reason why these individuals had it is certainly not being described. And possible explanations might be inflammation, myocardial fibrosis, or perhaps even coronary artery disease. So all these individuals went on to have a cardiac MRI to look for evidence of myocardial fibrosis. And this was what we found. The controls in the study group had no evidence of fibrosis. There was only one female veteran athlete with myocardial fibrosis. But interestingly, 16% of male masters athletes had evidence of myocardial fibrosis. And the distribution of this fibrosis was quite diverse. It occurred in the basolateral and infralateral wall, the septum, and in the apex. And if we look at the depth of the fibrosis, which will obviously give us a clue as to the cause, in around 60% of individuals, there was a mid-myocardial or an epicardial pattern of fibrosis, which hints at a possibility of previous myocarditis. But in around 40% of individuals, there was a subendocardial pattern, and this is highly suggestive of underlying atherosclerosis. So could these athletes who have a higher arrhythmic burden have a substrate in the form of myocardial fibrosis, which could be caused by underlying atherosclerosis? So the next step was to see whether or not they did have a higher burden of atherosclerosis. And here's what was found. So if we subdivide the cohort into controls and athletes and males and females, if we look at the presence of more than one plaque, you can clearly see that male athletes had the highest prevalence. And this was also the case with multivessel disease, a coronary calcium score of more than 300 Atkinson units, and the presence of 50% stenosis. And in fact, male athletes were the only individuals in the study population who had more than 50% stenosis. If we look at the data in terms of number of atherosclerotic plaques, controls had the highest prevalence of 0 plaques, but the presence of 1, 2, 3, or 4 plaques was much more prevalent in athletes. And again, if we look at maximal luminal artery stenosis, we can see that in athletes, the presence of more than 30% luminal stenosis in fact only occurred in athletes. And controls, some of which had luminal stenosis, was always less than 30%. And here's an example. This is a 64-year-old male masters athlete. And you can see quite florid calcification on the course of the right coronary artery and the left anterior descending artery. Now, so far I've mentioned that these athletes have a higher arrhythmia burden, they have more myocardial fibrosis, and have a higher incidence of atherosclerosis. Now, in our particular cohort, trying to tie these things up, there was 8 athletes who had more than 50% luminal stenosis. 3 of them had evidence of subendocardial late gadolinium enhancement, which is suggestive of atherosclerosis, and all 3 had evidence of non-sustained ventricular tachycardia. All these individuals were males, so there's certainly a higher risk phenomenon in terms of males who have a higher atherosclerosis burden, or more than 50% luminal stenosis. So this data was published recently, and it received a very good reception in the scientific community. But in the general media, it had caused a bit of a media frenzy. And these are some of the headlines that reported on the findings of the study. And as you can see for yourself, obviously it did raise some alarm. But I think the thing that these newspapers probably didn't focus on was that there was actually some very good news in this data, particularly for individuals who partake in multiple endurance events. And that is with regards to plaque morphology. Now, plaques are divided in terms of how much calcium they have within them, as either calcific, mixed morphology, or soft plaques. Now, calcific plaques are thought to be stable. They're less likely to fissure and therefore cause a myocardial infarct. And it's really, if you have an atherosclerotic plaque, you really would want a calcific plaque. So if we first look at females, athletes and female controls, they had a high prevalence of stable calcific plaques. And if you look at males, athletes and male controls, the male athletes had a higher prevalence of stable calcific plaques compared to the controls. And if we look a bit further, so these are different types of plaques, and they represent sort of the pathogenesis of myocardial infarction. And a soft plaque, as I mentioned, is much more dangerous. And these are reflected by population studies which have shown lower event rates in calcified plaques. So it could be that these athletes, although they have a higher prevalence of atherosclerosis, do in fact have much more safer or more stable calcified plaques. So it's not all bad news. And although we were the first to report these findings, a similar study by a Dutch group at around the same time confirmed our findings. And they also pointed out that these individuals have much more calcified plaques. And this is important because it means that these mass participants in endurance events do not become these unfortunate victims. And I think a good summary of the headline from the New York Times, which represented our research, was that exercise does play a toll on the heart, but you don't necessarily need to worry. And I think that's a fair reflection of the data that we presented. So what's driving all of this? Well, the honest answer is we don't know, but it's thought that in the presence of a hyperdynamic circulation, this may exert shearing forces on the arterial wall and promote downstream events such as inflammation, fibrosis, and atherosclerosis. But overall, it might be that we have to readdress the relationship of exercise and the heart. We know that as you do more and more exercise, you start observing rewards or benefits. But it might be that as you are on the tail end of high extreme endurance exercise, you do start seeing various features such as fibrosis, coronary heart disease, and arrhythmias, which at the moment we're still understanding. So in conclusion, lifelong high endurance exercise is associated with atrial and ventricular arrhythmias. The substrate for arrhythmias is likely myocardial fibrosis caused by occult coronary atherosclerosis. Male athletes have a higher prevalence of coronary atherosclerosis, but the predominant calcific morphology of the plaques in athletes could mitigate the risk of myocardial infarction. Thank you very much.